So first, I'd like to welcome everyone to come to this meeting at noon. So it's noon in Chicago and it's noon in Dallas. This afternoon we're going to talk about using topical oxygen to treat diabetic foot ulcers and its effect on pain. So my name is Larry Lavery. I'm a professor in the Department of Plastic Surgery at the University of Texas Southwestern Medical Center in Dallas. I'm the director of the Diabetic Limb Salvage Fellowship Program. It's a program that's been going on for about 8 years. We have 3 clinical fellows and a research fellow. And I'll present some of the work that our fellow has worked on as part of this presentation. So Robin Carlson is a physical therapist. She works at Advanced Wound Consultants in Chicago, or Evergreen Park, close enough. She's going to be our second speaker this afternoon, and she's going to talk about some of her research with pain with using topical oxygen therapy. So the objectives from my part of the talk is I'm going to talk about the latest scientific evidence with continuous oxygen therapy and look at some ideas about the mechanism of action. And then I'm going to review some of the clinical evidence to use continuous topical oxygen to treat diabetic foot ulcers. So this is kind of a fun topic because it really contradicts the conventions in this area and the accepted wisdom that you can't apply oxygen topically to a wound. It doesn't work. So this is really kind of pushback from hyperbaric medicine, which suggests that bringing oxygen to the wound relies on systemic circulation. So you treat people with 100% oxygen in a pressurized compartment. It increases oxygen carrying capacity of hemoglobin, which carries it to the wound and increases angiogenesis and wound healing. Topical oxygen takes a different approach, and it provides a local increase in oxygen at the wound site. There's a couple different approaches of this that have been commercialized, and the theory is really that you increase the local concentration of oxygen, you increase the partial pressure of oxygen to the wound, and it stimulates angiogenesis and increase in growth factor and increases local oxygen measurements at the wound area, and that has a cascading effect that increases angiogenesis and closes the wound. I'm going to talk about some of the mechanisms that we've explored, but not unlike hyperbaric oxygen, I think there's still a lot about this mechanism that we have to learn. So there's several devices that are clinically available. If you do a search of this, you'll find several things that have been commercialized. Most of them rely on periodic treatment of topical oxygen. So you get oxygen for a few minutes or a few hours a day. What we're going to talk about is a continuous treatment with topical oxygen and a device that's designed to give this treatment essentially 24 hours a day or as long as the device is applied. So some of the early rationale for this, or earlier explanations, is other studies have shown an increase in VEGF and an increase in cutaneous oxygen when topical oxygen has been applied to wounds. So kind of the basis for the study I'm going to discuss next was to kind of build on these experiences and maybe go a little bit deeper, a little bit longer, and see if there was other changes that could explain the benefits that have been observed clinically. So this is a study that was presented at the American Diabetes Association just a few weeks ago. This is a prospective cohort study. We looked at 23 people that had diabetic foot ulcers. We evaluated them over a 4-week period of time, and we looked at a couple of different parameters. We looked at differences in cytokines from baseline, and then we subsequently looked at changes in cytokines to see if there was a difference in responders and non-responders, or people that had at least a 50% wound area reduction at 4 weeks compared to people that didn't. We looked at a couple of measurements of perfusion. We looked at transcutaneous oxygen measurements and hyperspectral imaging measurements, both at baseline and over time, and then we also compared responders and non-responders. And then lastly, we looked at changes in quantitative bacterial cultures, the idea being that perhaps what happens is you provide a environment that is high in oxygen, and it is not as good an environment for bacteria to grow and proliferate in the wound bed. So this is the results of the first part of the study, where we looked at changes in cytokines from baseline. So V1 is baseline measurements, week 2, week 3, and week 4. So right away you can see, first of all, that there's pretty low levels of cytokines at the baseline measurement before we started therapy. And then in the first week, there's some big jumps with TGF beta, VEGF, like the other study showed, an increase in platelet-derived growth factor. Some of the inflammatory cytokines don't show an increase consistently or at all. But overall, you can see that there's an increase of gene expression in cytokines based on initiating the therapy and continuing therapy over the 4-week period of time. When you look, if you define a positive response or a surrogate for wound healing as a 50% wound area reduction at the end of 4 weeks, this graph shows the people that were responders, which are in blue, and the people that were not responders in red. So first of all, I want to just direct you to the baseline measurement that's 0, that's this blue line that forms baseline. So after 1 week of therapy, there's this big 40% increase on average in the people that had EO2, and a small increase in the people that ended up being non-responders. At week 2, there's a subsequent increase in the responders and a decrease or an increase in the wound size in the people that were non-responders that continues to the 4-week or the end of study mark. So on average for the responders, there was a 60% wound area reduction, and on average for the non-responders, there was about a 10% increase in the average wound size. So this is kind of the baseline information. As we move forward, I'm going to show you some of the changes in cytokines and inflammatory cytokines and growth factors, comparing responders and non-responders. So first of all, you saw what happened with growth factors, just comparing baseline measurements. So there wasn't a change in the inflammatory cytokines, except for IL-6 at week 4. That was an increase in non-responders and an increase in CXCL8 at week 1, and no change in TNF-alpha in responders and non-responders, and really no difference in responders and non-responders in the growth factors. Although you can see there's some areas that looks like there were trends, but with this small sample size, and in some areas pretty large variations in the measurements that we obtained, none of these were significant. So the next point of this is looking at perfusion. So when we looked at perfusion from baseline with either transcutaneous oxygen measurements on the medial lateral dorsum of the foot, or when we looked at it with hyperspectral imaging in either the medial and lateral dorsal angiosome or the medial and lateral plantar angiosome, there were no differences in perfusion or no increase from baseline that was observed. If you look at the responders and non-responders, at week 4 on the medial side of the foot, on the dorsum of the foot, there's a significant increase in transcutaneous oxygen measurement, but overall no change. If you look at hyperspectral imaging, overall again there was no change. And then there was no change with responders and non-responders. So this is just a photograph or a series of pictures of a patient with a wound and what the hyperspectral imaging looks like around the planar aspect of their wound, with the oxy, deoxy, and O2 saturation modes with this measurement. But again, overall, no significant change in perfusion compared to baseline or with responders and non-responders. We also didn't see any difference in quantitative bacterial cultures either throughout the course of the study or in responders and non-responders. We used a qPCR method, so we most likely identified significantly more bacteria than if we used kind of the traditional quantitative laboratory methods. But so again, no change in measurement of quantitative culture, either due to treatment or between responders and non-responders. Next, I want to talk about the evidence for a randomized clinical study. So this is a study that was published in 2018. It's a double-blind, sham-controlled randomized clinical study. Almost everything else we see in the diabetic foot that are treatments like platelet or skin substitutes, there's never a sham treatment. So this is a true active and sham treatment group. This was kind of a classic FDA phase 3 or phase 4 randomized clinical study. It was a 12-week study. Everyone in both groups got debridement ad lib and standard wound care with a really robust offloading approach. The difference was people that got the placebo, it was programmed so there was no oxygen delivered to the wound. So everyone thought they had an active treatment. Their wounds were debrided and dressed, and the continuous oxygen delivery was provided. Alarms went off and things like that. So patients had no idea if they got active or sham group. So it was a really nice control arm. So this is a post-marketing or a phase 4 clinical trial. It was really designed in consultation with CMS to make sure that we addressed, or the study addressed, parameters to support convincing them this is a viable product. We looked at differences in wound size and the chronicity of wounds, and we agreed to analyze both during the course of this study. So there's some interesting data. We also looked at percent wound area reduction and how that changed over time in both treatment arms. So really a classical clinical trial. There was a run-in period. If people didn't have a 30% wound area reduction, or if they did, they failed the study, then they were randomized and started treatments. Patients were seen on a weekly basis. Again, they had debridement ad lib as decided by the investigator, offloading in a boot, and standard dressing treatments. So this is how the consort diagram kind of rolls out. 386 people were screened, 225 people were randomized, and then people dropped out because of screening or withdrawal or early discontinuation. So 146 people were randomized and received treatment. So this is the start of the intent to treat phase of the study. 74 people received active treatment. 72 people were in the placebo group. And then there were 52 people that completed, and 50 in the active arm and 53 in the placebo arm that completed. And I'll talk a little bit about what the adverse events looked like during this study. 85% failed because of wound closure rates. So the primary outcome was the percent of wound patients or wounds that had complete closure or complete epithelialization with no drainage, which is the FDA definition of wound healing. And like other studies in the space, the secondary outcomes were the time to wound closure, and then we looked at effect of baseline wound size on wound closure and the duration the wound had been present on wound closure, and then adverse events. So to look at the demographics, there wasn't a difference in any of the demographic parameters in the treatment arms. The average wound size was 3.7 centimeters, so these are relatively large wounds. A lot of the RCTs in this space, the average wound size is 2.2 centimeters squared. The average age of patients was 56, and the majority, as in almost every study in this space, about 75% of participants are going to be male. So if you look at the study outcomes, to summarize, there's a higher proportion of wounds that healed. The time to healing was faster in the treatment group. There was a higher proportion of larger wounds that were healed in people that got topical oxygen. There was a higher proportion of chronic wounds that healed, and there were fewer adverse events overall. So if you look at the primary outcome in the intent to treat group, 32% of people in the active arm healed compared to about 17% in the control group, or about a twofold increased incidence of wound healing. So if you look at the rate of wound closure, time to closure was significantly shorter when in people that got the active treatment arm. So you can see how the days to wound closure go for 50% wound healing and complete closure. The time to 50% wound healing was there was about a 10-day difference. So as wound increased in size, the people that had active CDO actually had a higher rate of wound closure. So the larger the wound, the more likely it was to heal in the active treatment group. So it went from a twofold increase overall to, if you just looked at larger wounds, there was a threefold increased likelihood that you would heal if you got the active therapy in this group. Also, if you looked at weight bearing, at baseline, the percent of wounds that were on the sole of the foot were the same between each treatment arm. If you look at closure by the wound site, there were fewer, almost all of the wounds that healed in the placebo arm or the standard of care arm were on non-weight bearing surface. There was essentially the same proportion of wounds that healed in the active treatment arm in people that had EO2. So a higher rate of wounds that healed on the sole of the foot, about a 465% increase if you just look at wound site or wound location. Next, I want to talk. This was an additional study that we did. So this was a post hoc analysis looking at debridement and people that had wound closure in all the patients, first of all, and then in people that got active in sham treatment groups. So this is kind of a takeoff of the paper that Peter Sheehan first wrote that looked at where we initially started saying 50% wound healing at 4 weeks was a surrogate marker for complete healing at 12 weeks. So, like other biologic studies, if the wound is not debrided, so there isn't a good wound healing bed, most biologics, including oxygen therapy, just aren't going to be as effective. So we looked at, there was one site in the study that had a significantly lower rate of wound debridement, which was wounds were debrided about 40% of the time, compared to the other treatment arms that had a much higher rate of debridement. It averaged 98% of the time. And there was a significant difference in the proportion of wounds that healed in the active treatment arm in people that in wounds that had a high rate of ulcer debridement. So really similar to the Sheehan study that was a topical dressing or topical treatment application. So the relative improvement if your wound was debrided went from about 204% to 240%. So again, I mean, I think it's something that probably most of the people in this group are going to appreciate, but a lot of people outside don't really understand the importance of debridement. So this is a look at adverse events, and if you probably the most important and what drives a lot of the hospitalizations and complication is the rate of infection. So there was about 8% of people in an active arm, about 14% of people in the placebo arm that had wound infections, a lower, almost significant rate of people that had severe infections that required hospitalization, and 2 people developed gangrene at the wound site. By my count, if you look at the overall rate of wound complications, there were significantly fewer in the active treatment arm. So I want to pull some other studies up for comparison, first of all. So if you look at infections in other well-known treatment studies, so Applegraph, Dermagraph, Graph Skin, Graphics, in all of those studies, people that were in the standard treatment arm, about a third of patients developed an infection, and in the active arm, it was 18 or 20%. So usually a significant difference. And actually, the proportion of infections was much lower in the treatment arm and in the placebo or sham arm in this study. But if you look at the odds of wounds healing, in most of these studies, the odds are about a 2-fold increase in healing with active treatment compared to sham or standard of care arm, which is essentially what we identified in this group, was about a 2-fold increase, and that changed based on the size of the wound and the chronicity of the wound. I'll take just a few seconds to summarize, and then I'll turn this over to Robin. So this was really a nicely designed randomized clinical study with a true blinding of the investigators and a true placebo arm. So the run-in period, I think, effectively eliminated people that were going to respond if they just got standard of care, which is its purpose. And otherwise, I think a very rigorous offloading was provided, so the standard of care was high quality. The vast majority of people had wound debridement, and people that didn't respond as well. And as I said just a few slides ago, essentially all of the primary and secondary endpoints were successful in this clinical study. Higher proportion of wounds that healed, larger wounds, and wounds that were present for longer durations improved better or had a higher rate of healing compared to the control arm, and wound debridement had a significant impact. So with that, I will finish, and I will turn this over to Robin to talk about her work with pain in this space.
So greetings. Hope you're eating some good lunch, because we have some wound pictures to show. Thanks, Dr. Lavery. I work with Advanced Wound Consultants. I'm a co-owner, and we are a small group of nurses and physical therapists that work in conjunction with our vascular surgeons and infectious disease podiatrists, primary care doctors, and we just have a nice team. And so we were approached to be introduced to this device, to CDO, or Continuous Diffusion of Oxygen. And much like you might experience when you have a new product that comes along, or when you have a new device, you want to use it on your gnarliest wounds, the wounds that have been stalled, the wounds that you just can't figure out. You can't move it from one stage to another. So that's what we did with this device. And this was prior to any study. And when we did that, we saw some good results with wound healing, much like Dr. Lavery's study, and we were just impressed with the wound healing. But the patients told us about the pain relief. So why did we study pain? Well, because the patients were telling us that this was really a game changer for them in their pain. Yes, they wanted their wounds closed, of course, but the game changer was the pain relief. So let me tell you about how this pairs with pain reduce with the continuous diffusion of oxygen. Let's see. So this is a quote that perhaps you've heard before. This is from Dr. Paul Brand, who was an orthopedic surgeon and a medical missionary in Southeast Asia. And I just love this quote, that pain is a gift that nobody wants. So we know that pain is necessary. We work with our diabetic neuropathic wounds that have loss of protective sensation, and absolutely, they don't have the benefit of pain. So, but it's something that we don't want, of course. All kinds of wounds have pain. Think of your patients now: diabetic, neuropathic, vascular, pressure wounds, inflammatory wounds, surgical wounds. All these wounds have pain. But what we want to do is look at how we can interrupt that pain. So we go from the medical missionary in Dr. Paul Brand, who had so much work with leprosy patients or Hansen's disease, and did most of the work with starting out for total contact casting. And we move to the Buddhists, who say the pain is inevitable, but suffering is optional. So when you think of pain, we know the physical mechanisms for pain, but there's also so much else that's associated with pain. You have your context, your emotional input, your the suffering that you go through, maybe with dressing changes. There's the types of wound pain too. Diane Krasner has done a really thorough study of the types of wound-related pain. So we have the acute pain. Okay, you've all stubbed your toe in the middle of the night and you feel that pain incredibly so. But if you're in the middle of a battlefield, then you don't really feel the toe that you just stubbed. So you can have fresh acute pain with an injury. You can have chronic pain, might be associated with the underlying disease conditions you have. And then you have episodic or cyclical pain that might be associated with every dressing change or position changes. And then you have the pains associated with events. Maybe it's with debridements or with certain procedures. So we want to see how CDO was able to affect those kinds, just pain throughout the continuum. So did it? So we had a small pilot study, 20 patients and 23 wounds. And we saw patients either in our outpatient clinics or in their home setting. And the age of the wounds ranged from 40 days to 330 days. And the age of the patients were from 33 to 98 years old. So this is, let me tell you about Lily. Lily was a woman that I had known for a few years for different malleolar ulcers with both mixed etiology, venous and arterial etiology. And this wound, it doesn't look so bad and it doesn't look so big, but it was very, very painful. She was a little lady. She had a kind of a small world. She lived in an apartment and she had a little bit of walking to do, but this wound was present for 330 days already. And her initial pain when we started CDO was 9, but her fear of clinicians, mainly me, was off the charts. So whenever I would come to see her to change her wound dressing, she just had this fearful, timid look. And the other thing is that I couldn't communicate with her because she spoke primarily Spanish and she was incredibly hard of hearing. Her son had to take a megaphone to almost to her ear, and he would have to tell her what I was going to do. So I couldn't even share my stupid jokes with her to try and get her to calm down or anything like that, because there was just nothing that I could do to communicate with her about what I was going to prepare or what I was going to do. So she reluctantly agreed because her wound was so painful that she would try something else. So we put the device on. 3 days later, I went back and I didn't know what I was going to find when I opened the door. I hadn't heard from her, but she opened the door and she was not so apprehensive. She had a little smile on her face. And then I went back 3 days later, and this is 6 days after the application, and she said, "He perdido mi miedo." I hope I got that Spanish right. I've lost my fear. So this was incredible because Lily was ruled by her pain. And think of your patients now that are ruled by their pain. She wasn't eating, she wasn't exercising, she wasn't interacting with her family very well because she was in so much pain. So this was just a huge breakthrough. And look at her wound, by the way. Her wound looks great. Her wound has progressed quite a bit. 4 weeks later, her pain was at 0, and she had a very small wound at that point. She welcomed me in. She was happy to see me. And then in 39 days, after being open for 330 days, in 39 days, she was closed. The only addition to her treatment was continuous diffusion of oxygen. So we kept her in the machine a little bit longer while we continued her compression for a few more weeks, just to strengthen the scar and then allow her to transition to some mild stockings. That was Lily. So just to review what kind of patients we had in our study, they were all lower extremity, most were above the malleolus, and they were mostly this mixed etiology, a few surgical dehiscences, a trauma, and one diabetic heel ulcer complicated with pressure. And most of our patients had some form of edema, whether it was from their systemic or local conditions. So we mostly used some sort of compression on them that was commensurate with whatever their vascular status was. It was anything from a tubular sleeve to a short stretch to long stretch. And this is how we applied the device within that compression bandaging. We encouraged them to be as active as they normally could. This way that we applied it in the compression bandage, it did give us a little bit of a modicum of control because we want to make sure that it was stable in the dressing because they were wearing this we would change it either once a week or twice a week, depending on their exudate. And we used the OxySpurt dressing, which is a foam dressing where the tubing goes into the foam and then it is positioned over the wound. So I told you about Lily, and Lily had a small wound that was incredibly painful and impacted her all the time. This is Emma. Now I know you people all have stories about your wound care patients, right? So Emma is one of those. Emma is somebody that you should know. She's written up in the newspaper about someone you should know. She's always dancing. She's dancing in her apartment. She's dancing on the street. She is just a joy to know. So Emma had venous disease, both deep and superficial reflux. And she had this over a period of 40 years. I had known her about the last 10 years for venous ulcers that she had had. And she had had several venous ablations, and she was maximized vascularly for what she could take. Emma was someone who, her adult kids would tell me that when they were in elementary school, they would see her car pull up, and to pick them up, she'd open the door, she'd pour out the plastic bags of wound exudate, she'd usher them into the car, and she would put the bags back on, and she would go home. So Emma had significant venous disease for quite a while. So she had also this chronic underlying pain. Now she was active, she was very active, but it wasn't stopping her from doing those things, but she was describing this chronic pain. In January, we started the CDO on her. Her pain was at 7. And think of all the scar tissue over 40 years of venous disease that she had. So the wound healing was very slow going. But you can see in this slide in July that this was actually 53% closed. And we lost her to follow-up after that because she moved. And I really miss Emma. She's just, like I said, she's a special person. So what we know with Emma is that she had this chronic underlying pain. What she helped us to discover was that when she had the machine on, her pain was at 1. When she had the machine off, because either she forgot it on her nightstand, she forgot to charge it, oh, the tubing came out, I'm not quite sure how that happened. I think I walked away from the machine and discovered it 2 days later. She realized that her pain returned. So her pain made her pay attention to her device, because when she had the CDO on, then it was almost like a behavior modification thing that she started to wear it more and more to pay attention to it more because it actually improved her pain relief that much. So just looking at overall pain relief, and this really was something that got us. Everybody had pretty dramatic pain reduction, and their pain relief happened pretty quickly. Some people it was the same day, and some people it was, you know, over the first week or two. One gentleman I remember, he has sickle cell disease, and we had seen him a number of times, and he was one of our frequent flyers, and he was he would get these small ankle ulcerations, very, very painful. And he was a businessman, and he was embarrassed because now this was several years ago before the legalization of cannabis in Illinois, but he would have to go to the local drug market and get marijuana to reduce his pain. It was the only thing that worked. So when he came back into our clinic with a new wound and we approached him with the use of the device, he said, sure, I'm all for it. And we put it on, and he came back for his first dressing change, and he just was hopping in, and he said, I cannot believe it. He said, oxygen is my new drug. So that was pretty significant. When we looked at wound closure and pain, the wound closure was significant in 83%, significant or complete. And even in the wounds that did not close a lot, the pain relief was pretty dramatic. And it really, if you think back to Emma, it really did correspond to how often and how consistently they used the device. The pain relief was definitely commensurate with that. Some people would go in for a procedure and the CDO device would be disconnected, and they would notice right away that their pain would return. So we also noticed, because the patients would tell us that they greatly reduced their use of narcotics. So when, much like Dr. Lavery said, the use of topical oxygen has kind of been poo-pooed in the past, and you know, I was one of those. When I saw this device for the first time, I thought, topical oxygen, I don't think so. So I was not a believer. But I'll tell you, I just like you to consider thinking about this kind of thing. I mean, in the last 3 months, we've had to think out of the box quite a bit, right, with how our lives have been upended. But one of the greatest pains, I love this quote, one of the greatest pains to human nature is the pain of a new idea. So this created a way for us to think out of the box with oxygen for pain relief, because the patients were the ones who drove that thought process for us. So thank you for your time. I'll throw this back to Dr. Lavery.
Okay, we are going to take a few minutes and entertain questions from participants, if you have any.
Well, Larry, there have been quite a few questions. I'm going to read them to you. So the first question from Robert Freiberg, I think you know this gentleman. Why are there significant changes in cytokine expression and TCPO2 at 4 weeks, but not beyond?
I have no idea, Bob. I think so. This was a small kind of proof of concept study. I think probably this is the kind of technology that, I mean, so let me go back. As you know, this is a heterogeneous population. I think a lot of people don't appreciate how much variation there is between patient and patient. And so I think this is the kind of study that needs to be done in a larger patient population, and you know, for a longer period of time. So this was just kind of a taste that there's a signal there, and you know, otherwise I think it kind of gives us a foundation to move forward and to explore possibilities for mechanisms in the future.
Okay, thank you. The second question is from participant Cynthia Gordon, who asked, how was the control, so this came in at about 1:09, so about 9 minutes into your presentation. How was the control group treated, or were they all treated with topical oxygen?
Yeah, so pretty much everyone received offloading, debridement, standard wound dressings, and they just got a sham oxygen therapy device. So pretty much as equivalent treatment as you could get.
Okay, and a Mark Goldberg asked, how do these devices differ from the topical oxygen devices of, say, 20 years ago? What are the improvements?
I have no idea, because I mean, I saw some of the technology that people tried to investigate 20 years ago, but I have no idea what the science was behind their device. You know, at the time we were, you know, it's not really something that a company that has intellectual property in the device shares with investigators, and so I really don't know what the difference is in how their device was, the technology behind their device and the technology for the devices that are available today.
I think one of the big differences now that this is continuous diffusion of oxygen versus the episodic delivery that was, I think, for 20 years ago. I think that was.
So I think there's at least one device that maybe kind of came and went that I believe was continuous delivery of oxygen. I can't even recall the name, but you know, whether it really did that or how much oxygen it delivered, I'm unclear. But I mean, I think this, in today's market, I think this is the only product that provides continuous therapy.
A Daniel Cruz asks, have you seen better results as far as pain control in venous or arterial wounds?
What we noticed that, and maybe you've seen this in your practice, that those with arterial components have more pain or a different acuity of pain. So I think the pain relief seems to me more dramatic in those with arterial components to their wounds. And those with primarily venous, it was more of a dull underlying pain versus an acute. But that's just kind of our subjective take on it. A good area for further study, though, I can tell you that.
So Dr. Freiberg asks, what is the mechanism for such pain relief with CDO? Is it a function of the healing achieved, or is there some other factor contributing to this? Is this known?
It's a good question. I don't think we know the real mechanism of why it relieves pain, but the pain relief was pretty rapid even before the wound started to close. So I don't think it's necessarily tied to wound closure, but I think it's a different mechanism than just closure.
Okay, another question from Dr. Freiberg, who submitted quite a few. Why do you think we are now getting positive clinical TOT study results, but yet the infamous Leslie study, Diabetes Care 1988, showed such negative results? Is our oxygen just better now than it was in 1988?
You know, I'm not really familiar with the therapy or the device or the application, so you know, I can't comment on that study at all. Robin, any experience with that?
I do not know. I don't recall.
So Bob, I think I would hypothesize that depending on who did the studies, and like if you look at the early Regranic studies, wound debridement was done half the time, less than half the time, and I think you know, perhaps one of the differences is a lot of people that are participating in clinical trials now are used to more aggressively debriding wounds, and I think if you're going to have an active therapy like this, you have to have, you have to have that as part of your standard of care. I guess that'd be my only, without knowing the technology, that'd be my only comment.
So here's a question from Pamela Scarborough. Please review the infection biofilm component. One of my questions was is the biofilm impacted, and is one of the components that this device affects significantly?
So first of all, hi Pam. I wonder if it's raining in your part of Texas. So we did not measure biofilm. We just looked at quantitative bacterial cultures. There aren't a lot of studies that have done serial measurements of biofilm because, I think partly because it's expensive and you're just measuring a kind of a point in the wound instead of the whole surface of the wound. So we're just doing a count of a quantitative measurement of bacteria. No biofilm assessment in any way, and as far as I know to date, no evaluation of topical oxygen therapy and biofilm.
So Mark Goldberg would like to understand the configuration of the device. He says the old devices used to be a box that the leg went into. How are these devices applied? Could you describe this current device?
Yeah, so this is not that application at all, and because this is a CME presentation, I really couldn't show you this specific device in much detail, but it is much more, it has a very low profile compared to that application, and it's more consistent with a dressing you put on someone's foot than you putting your foot into some, you putting your whole foot or leg into a device. I think you can see this pretty readily if you go to this company's website. If you go to EO2 and look at the description and photographs and application of their product, it's pretty self-explanatory. But it's much different than the older technology or a lot of the older technology.
Okay, thank you. And Evelyn Hicks asks, are there any active studies going on with sickle cell anemia patients?
Not that I know of.
Not that I know of either.
There aren't a lot of randomized clinical studies in sickle cell patients because recruitment is really hard. So that's why you just don't see, if you look at in the literature for sickle cell stuff, it's not especially robust.
All right, well, if there are no further questions, I'll wait a minute to see if there are any more that come in. Let me just draw your attention to the CEH CME instructions, which you see on the screen now. You will receive an email with a post-event survey if you were connected to the webcast for the hour, or just short of an hour now, it looks like. Well, I'm seeing another question that came in. Well, so it's a comment and a question from Evelyn Hicks. She says, technology is obviously advanced from having patients with large machines to more smaller portable devices. Can you talk to patient compliance with this therapy? What's your experience been with patient compliance?
Robin, do you have any thoughts?
Well, I think I alluded to it a little bit during my talk that the pain that the person experienced allowed them an impetus to be more compliant with the device. Once they figured out that the pain relief was commensurate with the use of the device. So at least that happened in several patients. And They were pretty compliant. It also was integral to the compression product that we would put on. So we would apply the device along with the dressing. So that allowed them to be more compliant as well, because they just felt like it was a part of them. They didn't have to do anything with it. So.
Yeah, I agree. I think, we had a nice education component, because this was a study and we wanted things to be very consistent. And I thought our patients were really engaged using the technology, and we had people that came back and had ideas about, how to apply it better and things like that. So I thought our patients were really engaged, and utilization was really, really quite good.
A new question came in from Glenn Donovan. How would this device compare to an oxyband dressing?
I have no experience with oxyband, so I have no idea.
I have none either.
Okay, another question came in from Mark Goldberg. Do you see approval from CMS coming anytime soon?
Man, if anyone has a CMS crystal ball, I don't think they're CMS moves in mysterious ways, so I really have no idea. I think the study delivered pretty good evidence. With a well-designed study, we'll see how they respond. I have no idea how to understand what they do. Robin, how's your crystal ball?
I just like to say hope springs eternal.
Yeah. Yeah.
Well,
That's it.
As well. Deborah Mannheim asks, is this device being used in small private practices or mainly large wound centers?
I think that's I don't really have insight into sales or that. I think you could probably talk to your the local rep for this product. I don't really have any insights into answer that question.
Yeah.
Okay, that's fair. Question from John Sikovic. Do you have any insight regarding surgical incision pain, particularly after amputation?
It's interesting that you bring that up, because I can see, I really would like to use that and see if that is a very effective treatment for that, both for wound closure or incisional maturation, as well as for pain relief. So that's a really good question, and one that maybe you could take up the baton on that one. But yeah, I see a good role for that there.
Well, so my patients don't have pain usually, but for in people with diabetes, the weight of the frequency, I should say, of at least part of wounds failing after amputation or surgical closure is pretty high. It really isn't reported. I mean, there's very few reports in the medical literature about it, but I think this might be one of the technologies to look at to see if you can reduce the rate of wound failure.
Yeah.
Larry and Robin, thanks very much for your presentations today. I don't see any more questions coming in. So I think we can conclude.
Okay.
Thank you very much. I appreciate your time. Thanks, Robin.
All right. Thanks, Dr. Lavery.